Module 3, Lesson 3 focuses on agents used in anemias and hematopoietic growth factors. This lesson is divided into the following subtopics. First, we have hematopoiesis, followed by discussing erythropoiesis, and then anemia. In anemia, we will be lecturing the specific agents used in the treatment of such condition, like iron, vitamin B12, and also folic acid. And then finally, discussion on hematopoietic growth factors used as drugs. Hematopoiesis is defined as the formation of blood components such as red blood cells, white blood cells, and also platelets. Red blood cells are also known as erythrocytes, and white blood cells are also known as leukocytes. Whereas for platelets, these are called as thrombocytes, and these are also known as thrombocytes. The primary site of hematopoiesis is in the red bone marrow, in which it is found between the trabeculae of the spongy bone tissue. In order to form blood cells, the pluripotent stem cells in the red bone marrow produce two further types of stem cells, which have the capacity to develop into several types of cells. These stem cells that came from the pluripotent stem cell are the myeloid stem cell and also the lymphoid stem cells. The myeloid stem cells begin their development in the red bone marrow and give rise to the following. Number one are the red blood cells or the erythrocytes, also platelets or the thrombocytes, which came from megakaryocytes, and also we have monocytes, and aside from monocytes, we have neutrophils, eosinophils, and also basophils. These components are called as granulocytes. And finally, also coming from the myeloid stem cells are the mast cells. Whereas the lymphoid stem cells, which give rise to lymphocytes, begin their development in the red bone marrow, but complete it in lymphatic tissues. Examples are the T lymphocytes, the B lymphocytes, and also we have the natural killer cells or the NK cells. Focusing on erythropoiesis, this is defined as the formation of red blood cells or erythrocytes. It starts in the red bone marrow with a precursor cell called proerythroblast. The proerythroblast divides several times, producing cells that begin to synthesize hemoglobin. Ultimately, a cell near in the end of the development sequence ejects its nucleus and becomes a reticulocyte. Loss of nucleus causes the center of the cell to indent, producing the cell distinctive biconcave shape. They pass from the red bone marrow into the bloodstream by squeezing between plasma membranes of adjacent endothelial cells, and then the reticulocytes begin to mature finally into red blood cells called erythrocytes within 1 to 2 days after their release from the bone marrow. In the life cycle of erythrocytes, red blood cells live only for about 120 days because of the wear and tear of their plasma membranes whenever they squeeze through the blood capillaries. This life cycle is divided into several steps or several processes, but we will just focus on the first 8 steps indicated in the figure. Again, in the first 8 steps. Number one, macrophages in the spleen, liver, and red bone marrow phagocytize ruptured and worn out red blood cells. And in the second step, the globin and the heme portion, of hemoglobin are split apart. Third step, globin is broken down into amino acids, which are further reused to synthesize other proteins. Next, number 4, iron is removed from the heme. Iron is removed from the heme, and it is being associated with transferrin, which is a carrier protein or a transporter protein in the bloodstream. In the 5th step, in the muscle fibers, liver cells, and macrophages of the spleen and liver, the iron in ferric state detaches from transferrin and attaches to an iron storage protein called ferritin. So the difference between transferrin and ferritin is that transferrin is the carrier, while ferritin is the storage iron, a storage protein for iron. Number 6, on release from a storage site or absorption from the gastrointestinal tract, the ferric ion reattaches to transferrin, and then the complex is then carried to the red bone marrow, where RBC precursor cells take it up through receptor-mediated endocytosis for use in hemoglobin synthesis. Iron is needed for the heme portion of the hemoglobin molecule, and amino acids are needed for the globin portion. Vitamin B12 is also needed for the synthesis of hemoglobin. And then finally, on step 8, erythropoiesis in red bone marrow results in the production of red blood cells, which enter into the systemic circulation. So this is the life cycle of erythrocytes, beginning on first step, wherein the worn out red blood cells will undergo phagocytosis until it will be reused for another round of erythropoiesis for blood circulation. Next is the regulation of red blood cell production. Normally, erythropoiesis and the red blood cell destruction proceed roughly at the same pace. If the oxygen carrying capacity of the red blood cell falls because the erythropoiesis is not keeping up with the red blood cell destruction, a negative feedback mechanism steps up the red blood cell production. So usually the stimuli of imbalance in the red blood cell and oxygenation in different parts of the body are, number 1, hypoxia. So if there is hypoxia, that could be a trigger for the imbalance, a hypoxia. Aside from tissue hypoxia, another is anemia. We have several reasons for anemia to occur, like for example, iron deficiency, if you lack iron, also lack of certain amino acids, and lack of B12, or deficiency in vitamin B12. So once there is an imbalance, that triggers release of erythropoietin, that would result to release of erythropoietin by the kidneys. Erythropoietin, remember, is the one that stimulates erythropoiesis in the red bone marrow cells, and through erythropoiesis, more red blood cells will be produced that came from reticulocytes, and that's why when there is higher concentration of red blood cells produced, a more amount will be available in the carrying of oxygen that will be delivered to tissues. That's why the imbalance will be restored. Next is discussing anemia. Remember that anemia is one of the stimuli for oxygen imbalance in different parts of the body. Anemia is defined as a deficiency in oxygen carrying erythrocytes or red blood cells. It is a deficiency that is considered as the most common and can be easily treated. Although there is a specific type of anemia called sickle cell anemia, which is a genetic disorder that is not easily treated, but others are easily treated or treatable. There are 3 essential nutritional requirements for red blood cell production, and thus are effective in the treatment of anemias. These are iron, vitamin B12, and also folic acid. So we will discuss each of these agents, and then we will tackle their pharmacology and also their clinical applications. Iron facts. The human body contains an average of 3.5 grams of iron, particularly for males 4 grams and females 3 grams. Iron is important for efficient oxygen transport, energy production, cellular growth, and also proliferation. In fact, a majority of iron, that is 70% of the absorbed iron, is being attached with the porphyrin ring structure, forming heme that is needed for binding with oxygen that would be distributed or that would be given to different tissues. And about 10 to 20% of absorbed iron is stored in ferritin molecules. Remembering ferritin, these are proteins that are needed for storage in different areas, such as in the liver. The table shows the iron distribution in normal adults, like for instance, iron found in hemoglobin, in myoglobin, in enzymes, and also in transport proteins like transferrin and also storage in the liver. That's why we tend to conclude that we need a considerably huge amount of iron for normal functioning in the body. The figure shows the absorption, transport, and also storage of iron. And there are different parts that you must recognize. Number one is in the gut lumen. Second is in the bone marrow erythrocyte precursor. Third is in the liver cell or in the hepatocyte. And then finally, in the macrophages and in the spleen. Intestinal epithelial cells actively absorb inorganic iron via divalent metal transporter 1 and heme iron via the heme carrier protein 1. For example, this is iron. Okay, this is iron. So this is actively transported through the DMT1 and also HCP1. Iron that is absorbed or released from absorbed heme iron in the intestine is actively transported into the blood by ferroportin, and stored as ferritin. Okay, this is being stored as ferritin. In the blood, iron is transported by transferrin. Iron is being transported by transferrin to erythroid precursors in the bone marrow for the synthesis of hemoglobin. That's why there are iron being transported by transferrin that move into the bone marrow erythrocyte precursor through receptor-mediated endocytosis. So the iron portion will be needed for synthesis of hemoglobin, which is needed also by red blood cells during erythropoiesis. The transferrin iron complex binds, or in the blood, iron is transported by transferrin, and then it also moves into the transferrin receptors in the hepatocytes and then undergo receptor-mediated endocytosis. In other words, aside in the red bone marrow cells, this transferrin iron complex can move into the hepatocytes. After release of iron, the transferrin complex is recycled to the plasma membrane, and then the transferrin is being released. And finally, macrophages that phagocytize senescent or dead red blood cells reclaim the iron from the red blood cell hemoglobin and either export it or store it as ferritin. Hepatocytes use several mechanisms to take up iron and store the iron as ferritin. Iron is bound and transported in the body via transferrin and stored as in ferritin molecules. Once iron is absorbed, there is no physiologic mechanism for excretion of excess iron aside from blood loss. For instance, in pregnant women, also during menstruation, and also during bleeding tendencies. That's why women are more at risk for iron loss compared to men. Next. Iron deficiency is the most common cause of chronic anemia. This is because iron is important for heme formation, and together with the globin proteins, hemoglobin is being synthesized. As you learned, hemoglobin is important for oxygen transport. Thus, less heme formation or less iron would mean less heme formation. And when there is less heme, less hemoglobin, thus less protein would be available for oxygen transport. That's why during iron deficiency anemia, there is less oxygenation that leads to paleness, fatigue, dizziness, dyspnea, and other generalized symptoms of tissue hypoxia. Also, in iron deficiency, absence of adequate iron can cause what we call microcytic hypochromic anemia. Microcytic because it's smaller than the normal red blood cells. Hypochromic means pale, a less chrome or pale. You can check on the table the features of iron deficiency and other nutritional anemias, particularly in iron. Deficiency of iron can cause microcytic or small size, and then pale red blood cells. Other nutritional deficiencies will be lectured also later. Since iron is important for heme production, iron supplementation would be helpful in the treatment of anemias caused by iron deficiency. So first, we can administer it through oral, and then pwede rin ang parenteral preparations or parenteral administration. So as to correct anemias and replenish iron stores, we can use again oral and also parenteral iron therapy. Ferrous iron is most efficiently absorbed, so only ferrous salts should be used for oral administration. Treatment must be done or must be continued for 3 to 6 months to ensure correction of anemia and replenishment of iron stores. The following are the adverse effects associated to oral iron therapy. Number 1 is nausea, epigastric discomfort, abdominal cramps, constipation, and in some cases, diarrhea. This is usually dose-related. Hence, these adverse effects could be managed by modifying the dose, such as lowering the dose. And in some cases, patients also develop black tarry stools. For parenteral iron therapy, this is applicable to patients who are unable to tolerate or absorb oral iron, such as those patients that suffer extensively from gastrointestinal adverse effects. Also, this is indicated to patients with chronic anemia and cannot be maintained using oral iron therapy, such as in patients with chronic advanced renal disease. Also, those patients who had undergone post-gastrectomy, and then inflammatory bowel disease, and finally, malabsorption syndromes. In the United States, there are 3 commercially available parenteral iron therapy, like iron DEXTRAN. Also, we have sodium ferrous gluconate complex and iron sucrose complex. Amongst these 3, the most commonly used one is the iron DEXTRAN. Usually, iron DEXTRAN is being administered via deep intramuscular injection or through IV infusion. Between the two, it's more convenient to use intravenous administration because it eliminates local pain and also tissue staining, unlike IM that can cause both problems or both inconvenience to the patients, like local pain and tissue staining. Adverse effects of IV iron dextran therapy include Number one, headache, lightheadedness, fever, and arthralgias, nausea and vomiting, back pain, flushing. In some cases, there could also be urticaria, bronchospasm, which are immune-mediated, and anaphylaxis. So during anaphylaxis, small test dose should always be given before full IM or intravenous doses are being administered, so as to check first if the patient could suffer from severe allergy when exposed to iron dextran. Next, regarding the adverse effects of using iron, it depends on the duration of exposure. There are toxicities caused by brief exposure, and there are also toxicities caused by prolonged exposure. For acute iron toxicity, this is being seen almost exclusively in children who accidentally ingest iron tablets. That is, 10 tablets could be lethal to them. That is because preparations or oral preparations containing iron look like candies because the color is appetizing. That's why children usually think that iron preparations are like candies. That's why they have a huge amount of being ingested by them. Symptoms include necrotizing gastroenteritis with vomiting, abdominal pain, and bloody diarrhea. In some situations, there could also be shock, lethargy, and dyspnea. Treatment is being done through full bowel irrigation to flush out unabsorbed iron. Second, we have deferoxamine, which is a potent chelating agent. Note class that activated charcoal is not effective here because it doesn't bind to iron. Whereas during chronic iron toxicity, that is medically called as hemochromatosis, this is characterized by excessive iron being deposited in organs like the heart, liver, pancreas, and others. This could lead to organ failure and ultimately death. This commonly occurs in patients with inherited hematochromatosis and in patients who receive many red blood cell transfusion over a long period of time. Treatments include, number one, the primary treatment is through intermittent phlebotomy, in which 1 unit of blood can be removed every week or so until all the excess iron is being removed. Take note that chelators like deferoxamine and deferasirox are only alternative agents because they are less effective during chronic poisoning. Another agent used in anemia is vitamin B12, also known as COBALAMIN. Humans cannot produce vitamin B12, hence it must be obtained from the diet, such as by eating meat, such as liver, eggs, and also dairy products. This is used in the treatment of megaloblastic and macrocytic anemia, neurologic symptoms, and gastrointestinal symptoms. Parenteral injections are required for therapy, such as those that are caused by vitamin B12 deficiency. So during vitamin B12 deficiency, this is often caused by malabsorption of vitamin B12 in the gastrointestinal tract. An example of a condition that is characterized by malabsorption of B12 and thus leads to B12 deficiency is during pernicious anemia. That is during pernicious anemia. Pernicious anemia is an autoimmune disease that results to inability of the body to produce the so-called intrinsic factor. So the body cannot produce inability to produce intrinsic factor. Now, what is intrinsic factor? Intrinsic factor is being synthesized by the parietal cells of the stomach. Okay, this is being synthesized by the parietal cells of the stomach, and it aids in the absorption of vitamin B12. So it aids in the absorption of vitamin B12 in the GI tract. Hence, if there is pernicious anemia, there is remarkably low levels of intrinsic factor. If there is low level of intrinsic factor, there will be no assistant for the absorption of vitamin B12. Hence, there is reduced B12 absorption or malabsorption of vitamin B12. That's why patient could develop vitamin B12 deficiency. The patient could develop vitamin B12 deficiency. And when there is vitamin B12 deficiency, this could lead into the following problems like megaloblastic anemia, neurologic symptoms, and gastrointestinal symptoms. Okay? As we recall, the stomach produces intrinsic factor in the parietal cells of the stomach, and it is the one responsible for the absorption of B12. So in conditions like pernicious anemia, that is an autoimmune condition, there is no intrinsic factor. That's why B12 cannot be absorbed, leading to deficiency. Such deficiency finally leads to effects like megaloblastic anemia, GI, and neurologic symptoms. In the treatment of conditions related to B12 deficiency, parenteral injections are required for therapy. Available, vitamin B12 is usually available as cyanocobalamin or hydroxycobalamin, and the initial dosing is 100 to 1,000 micrograms intramuscular injection. And maintenance is 100 to 1,000 microgram intramuscular injection, but once a month only. For the initial, it's every other daily or every other day. Finally, we have folic acid. Reduced forms of folic acid is important for essential biochemical reactions like amino acid synthesis, purine, and also DNA synthesis. Folate deficiency is usually common that could lead to anemia and congenital malformations. Treatment of folate acid deficiency can be used. Treatment of folate acid deficiency, such as in patients in megaloblastic anemia, could be applicable in patients with alcohol dependence, liver disease, malabsorption syndromes, and also patients undergoing hemodialysis. And since deficiency of folic acid could lead to congenital malformation, pregnant women and also patients with hemolytic anemia, they require high folic acid requirement. Folic acid 1 milligram daily is indicated in almost all patients, and this amount is sufficient to reverse megaloblastic anemia, to restore normal folate levels, and replenish stores of folates. Additionally, as we said, this is indicated to high-risk pregnancy or high-risk patients in pregnancy that is in the prevention of congenital malformation, particularly neural tube defects. So after discussing the agents used for anemia, we also have hematopoietic growth factors like we have erythropoietin, marketed under the brand name epoetin alpha and epoetin beta, myeloid growth factors, and megakaryocyte growth factors. This table shows the clinical uses of hematopoietic growth factors and agents that mimic their actions. You can see the clinical conditions being treated by the hematopoietic growth factors. So for erythropoietin, we have for anemia. So this is related to red blood cell deficiency. Granulocyte colony stimulating factor is indicated for neutropenia. In neutropenia or less amount or abnormally low level of neutrophils. Also, we have granulocyte macrophage colony stimulating factor, which can be used for stem cell transplantation. Interleukin 11 for thrombocytopenia. And then we have rumiplastim for thrombocytopenia as well, or low platelet levels. Overall, this ends our discussion on hematopoietic growth factors and treatment for anemia. Remember, for anemia, we only use iron, B12, and folic acid. The main point of using them is to supplement the lacking. And then for the hematopoietic growth factors, erythropoietin, megakaryocyte, and also myeloid growth factors. That's the end of our discussion.